Good morning, everybody. I'm Dr. Mary Schroth. I'm a pediatric pulmonologist here at the university. I, too, want to thank you all for coming. This is so exciting to have all my families in a room together, as well as people on a webcast, which is really exciting for us. So I hope you get a lot out of today. I want you to use this as an opportunity to get to know each other. As I say a lot in my presentations, I can give you some information, but it's really what you learn from each other, because you guys live this every day. I just know how it is from the medical side, and I know what you guys have told me, what works, what doesn't work, about what I recommend. But you guys have to figure it out every day. So take advantage of chatting with each other, and we hope there'll be plenty of opportunity for that. This is a fairly relaxed environment. If you have questions, please ask as we go. I only get an hour, though. And then, you can always catch me later, and people email me. And I do my best to answer your emails, but I really bear with. This is my favorite part about my job, are the pictures. So I love it when you send me pictures. So, if you want to send me something, get me something, send me pictures of your kids and your family. Those are great. And let me know if you don't want me to share them. If you don't want me to share them, I won't. But you have to tell me that. Otherwise, I'm going to assume that I can show them to the rest of the world. All right. So the things that we're going to talk about are how SMA affects breathing. I'm really going to focus on the respiratory part. That's what I know best. We're going to learn techniques, review techniques for many of you. So help your child's breathing. And realize you have choices. You don't have to do everything that I talk about. You have choices in what you provide to your child. But I want you to have the tools and want you to know what those options are. So this is a document that a group of physicians put together a couple of years ago now. Dr. Wang led this group. He's a neurologist at the University, or Stanford University. And it covers 5 topics. It's a standard of care document. It covers diagnosis, respiratory care, GI and nutrition, orthopedic and it's written in doctor speak, but I know that they're available on the Families of SMA website, the parent version of it or the layperson's version of it. So look for this document. If you don't have it, I can also provide you with a copy. But I encourage you to use it and share it with other physicians that are providing care to your child. So when I think about respiratory function in SMA, and are there any type 3s? Families with kids with type 3, not in the room, but possibly in a webcast. In type 1 and type 2, the respiratory muscles between the ribs are very weak. They're essentially paralyzed. They don't work well. So when they take a big breath, it comes from the belly. So the diaphragm muscle is the muscle that they use primarily for breathing. That chest wall is also really soft and flexible during the first year of life. So and in comparison to SMA type 3s, they usually have normal lung function and normal chest wall movement throughout their lifetime. But as they get older, they may develop other problems like obstructive sleep apnea, and they may have trouble with respiratory weakness, especially during colds, but not to the degree of the type 1s and type 2s, and also during surgeries. So normal chest wall, you use that upper part of your chest to take a breath in, and the chest wall expands at the top. For kids with SMA, it just comes from the bottom. And over time, what happens is that the kids will develop a bell-shaped chest because it looks like someone just grabbed them at the bottom of the rib cage and pulled straight down. There's no muscles count as a counterforce to the diaphragm. So what happens is that kids with SMA have difficulty coughing. We're going to spend a lot of time talking about that. They're at risk for having small, shallow breaths during sleep, not taking big enough breaths to support their breathing. For the younger kids, the type 1s and weaker type 2s, their chest wall and lungs may not be fully developed because, again, they don't get this chest wall expansion, so the chest isn't growing. And they also develop recurrent infections because they just can't fight off those infections. They can't cough and they aren't taking deep breaths. So this is it's sort of a complicated graphic, but just to go through sort of the natural history of SMA, if you don't do anything at all for type 1s and the weaker type 2s, this does not apply to the type 3s because they generally won't get into what we call respiratory failure. But all of our kids start off with normal breathing. And we can evaluate that by physical exam. Over time, they may develop breathing and swallowing difficulty. Every child with SMA type 1 loses their ability to swallow. The weaker type 2s may also lose their ability to swallow. That's the natural history of the disorder. The type 2s and stronger type 2s will maintain their ability to swallow, but just may not be able to eat enough calories to maintain their weight and growth. And we can evaluate muscle strength, breathing muscle strength by doing pulmonary function testing, and we don't do this until the kids are about 5 years of age. But they can cooperate and they can take big breaths from me and blow out as hard as they can, and we can measure their lung function, how big their lungs are, and also how strong the muscles are for breathing. If their muscles are weak, we teach you airway clearance techniques. As things progress, as the kids get weaker, they can develop dream-related sleep disordered breathing, which means during REM sleep, they may not take big enough breaths, and their oxygen saturations may drop and carbon dioxide levels may go up. There's also progression through the weak cough, and then a measurement called peak cough flow, where essentially we have the older kids cough into a device that measures how fast they're coughing, how fast the air comes out. We can evaluate things by doing chest x-rays and sleep studies to see where as weakness progresses and respiratory failure progresses, there will also be problems during sleep with non-dream sleep. And what we'll see is that kids will drop their oxygen saturations, may need oxygen during sleep, or other intervention, which is what I recommend as another intervention. Swallowing dysfunction will happen. And we can evaluate swallow function with a swallow study. And we can also start non-invasive ventilation when we have the difficulty during sleep at night. So these things, the weak cough, swallowing function will lead to chest infections. And if you develop chest infections, that also contributes to the sleep disordered breathing, more problems. We can progress, the child can progress to needing oxygen during the daytime as well. And then if that continues on, the child will die, the individual will die. This is a typical course for respiratory failure in anyone. But in SMA, that timeline is much faster depending on how weak you are. So the ways that we look at respiratory status is when you bring your child to me, I spend a lot of time looking at the child. It's not that I'm ignoring you. I'm just really trying to learn how your child is breathing, how they're doing. Are they having a lot of difficulty? So direct observation is very important in respiratory status in this population. I can do respiratory and muscle function tests in older kids. Again, they have to be about age 5 in order to do that. Many of my kids hate doing that test because they have to take a big breath in, exhale, and then we put a shutter across the device they're breathing into. And it's a little weird, but it gives me a sense of where their muscle strength is. I also look at how fast they're breathing, where they're breathing. Paradoxical breathing means the belly goes up on inhalation rather than the chest wall, which is how all kids with SMA 1 and 2 breathe. For non-sitters, we can also do additional tests. Chest x-rays give me a sense of, are we developing pneumonias, atelectasis, which means collapse of the air sacs. Swallow study, if I'm concerned about swallowing, loss of swallow, and scoliosis x-rays. Scoliosis is something that will happen over time in SMA. For sitters and walkers, I do pulmonary function tests when they're old enough. I may do a sleep study if I'm not sure if they require assistance during sleep. And then also scoliosis x-rays to monitor what's happening with their spine. So those complications of swallowing function and scoliosis have a huge impact in respiratory function. Things that are very important to monitor. So when we talk about chronic management or day-to-day management of respiratory issues in kids with SMA, we're balancing a number of things. I mean, we're trying to keep the kids home for as long as we can, trying to keep them help their survival for as long as possible, but we also want good quality of life and comfort. And we want to be able to provide you as families with resources to do all of these things. And that's tough. There's just a lot of things we're trying to accomplish. What we've learned over the last many years is that early, aggressive, and proactive intervention may prolong life without compromising quality of care. So Dr. Kaufman at Columbia University actually did a study looking at the international registry for SMA. It's actually it's the registry that families can do collectively through the University of Indiana if you're interested in participating in research. went through that database and looked at what's making a difference in survival. And the two things that you found that are making a difference are good nutritional support. They're getting gastrostomy tubes and they're getting good nutrition early, and respiratory support. So doing BiPAP and cough assist and all the non-invasive techniques that we're talking about today. So for you as families, what's important is to recognize when your child changes. So when things are different. And a lot of you have sort of like a sixth sense about that. And you know when things are changing before you can tell me what's changing. You just know that something's different. That's important to recognize. Airway clearance is very important, and we'll talk a lot more about that. And I break down into assisted coughing and secretion mobilization, respiratory support, and palliative care. Okay, who doesn't have a cough machine for their child? Okay, we'll just move right along. So on the left is the older inexaflator cough machine. On the right is the cough assist. And I can tell you that Respironics is developing a newer version that has a battery with it and hopefully will be more portable. But that's been going on for a couple of years now. So don't hold your breath, but we're hoping for a better, more portable device. This is work by John Bach. I always have to acknowledge Dr. Bach. He's done a tremendous amount of work. And the things that I do really were based on things that he started. A physiatrist at the University of New Jersey developed a lot of the non-invasive techniques that we're using to support kids with neuromuscular weakness. And he demonstrated that the cough machine could provide normal cough flow if used appropriately. So for people who are very weak, their cough flow is around 2. If you don't help them, they're just doing their cough, which is usually or assisted cough, which is actually a manual cough assist, where you can either take your fist or you take your open palm and you go into the diaphragm under the rib cage and you're pushing on as they're trying to cough. That's a manual assisted cough. And the exaflator, which is the mechanical inexaflator. The normal cough flow is 6 to 12 liters, and we can normalize their cough by using this device. So the settings that I use, and I think you all have heard this from me, is we start at a pressure of 30 and we try to move it up to 40. And we do it for 1 second on the inhale. For the exhale, we do start at -30, work up to 40 for 1 second, and pause time 1 to 2 seconds, depending on what your child tolerates. As the child gets older, they can tell you, which is really nice. They can give you feedback. You know, does it feel like they're getting a big enough breath? Does it feel like they're helping them cough? Do they need more pressure? And they can tell you that. What we do is we do 5 sets in a row, 5 breaths in a row. We put it on the automatic setting, so it goes inhale, exhale, pause. Ideally, we use a manual cough assist with a cough machine, but if there's only one person doing it, you can really. It usually takes 2 people if you're going to do a manual cough assist as well as use the cough machine. And section the upper airway or the tracheostomy tube or the endotracheal tube after doing the cough machine. And we use it as often as we need to. So you all understand that the cough machine essentially simulates a cough. When you cough, you take a big breath in, you close your throat, and then you burst the air out. This device puts air into the lungs, and then it sucks it out. And what's important is just coaching the child. Like for babies who are just starting to use it, is to tell them to take a breath in when the machine is breath, and then to cough when it's going to cough for them. So to have a set rhythm. The downside of the cough assist machine is it doesn't synchronize with you. You have to teach the person who's using it to work with it. Yes?
When would you use the cough machine and a manual?
If someone was really sick.
Okay.
Now, if the oxygen saturations were dropping, they were really sick, and we just weren't, and you felt like they were plugging up and not moving secretion. In the hospital, we've done it. It's just hard. If it's just you're trying to hold a mask on, you can't do it all. But if someone's in a lot of trouble and they need to cough, you do both. So for the younger kids, and for kids who aren't on BiPAP, so type 1s, type 2s, the 3s don't need to do this, because again, they have normal chest wall expansion. But we'll do things to do chest wall expansion to help increase that chest wall. Kids who are on BiPAP, we see dramatic improvement in their chest wall shape over time. And I'll show you some photos of that. Bang breaths, help expand the chest wall. Or we can use the cough assist machine on the inhale mode only. So in order to do that, you set the inhale as you normally would, set the exhale time at 0. So just go from inhale to pause, pause, and you get a nice stretch of your chest wall. So that's one way to exercise the chest, especially for kids with type 2 who are not using a BiPAP. So that's coughing. So now let's switch to talk about secretion mobilization techniques. So there's a lot of things that you can do to help just move those secretions around. The most common thing, and the thing that we teach you first, is chest physiotherapy, usually with palm cups. We also use an electric percussive. We teach you postural drainage, which is tipping the kid head down, butt up, on an angle. So you're using gravity to get the secretions to go from the little airways to the bigger airways, so they're easier to get out. And a pulse oximeter, and we'll talk a little bit more. So there's other techniques that we use, but they're not proven. And I don't recommend all things for all patients with SMA. On the left is a home IPV machine, or intrapulmonary percussive ventilation. We use this in the hospital, especially after surgery. And we use it if the kids are really sick. It will move a lot of secretions very quickly. And sometimes people get a little freaked out by how many secretions come rolling out, because you have to pop the child fairly quickly after you start. The kids are really sick. They can flood their airways with secretions. Also, not every child tolerates IPV. It sounds like a choo-choo train. It's like what we're doing is we're putting air into the lungs with a mask or a mouthpiece, and it goes boom, boom, boom in the lungs. So it's like doing chest PT on the inside of the lungs with air. You're just trying to mobilize the secretions, loosen them up. Another device that's commonly used is a vest therapy, and that's doing literally a vest that you put on, and it has an air source that just puts air into this vest at a set frequency and pressure, so it squeezes, shakes, and it helps to loosen the secretions. And that's very well tolerated.
My phone a little bit closer.
Oh, sorry.
That's fine. You're good.
Okay. They're both good devices. The thing is that there's no one device that's better than any other. It's what works for your child, and what works for your family, and what gets those secretions up. So this is postural drainage. I don't know how well you can see it, but the child's on a wedge. So head's lower than the chest. So that, again, you're trying to get those secretions from the small airways to the bigger airways, so they're just easier to cough out. The other thing I want to just remind everybody about is that our kids, the weaker kids, the type 3s may not be able to tolerate this, but the type 1s and 2s actually do better when they're laying flat or they're tipped head down in that postural drainage position or Trendelenburg. The reason for that is that when you're in a head down position, there's a part of your lungs that you can never exhale to. Like when you exhale, there's always some air left in your lungs. When you're tipped upside down, that amount left in your lungs is at its lowest amount. There's actually more air or more lung for the kids with SMA to use when they're either flat or tipped upside down. So when your child is in respiratory distress with a type 1 or type 2, you want to lay them down. Don't sit them up. You know, in the hospital, our natural reaction to anybody who's having difficulty breathing is to sit them up. And that's just what we do. But, you know, my team and many people out there have learned that, nope, you need to lay the kids flat. So just remind people, if you end up in a hospital somewhere, having trouble, flat, or head down. Pulse oximetry is a really important tool for kids with SMA type 1 and 2. And again, the 3s don't have the same sorts of issues. The thing is that the weaker kids do not show you they're having difficulty breathing until they're blue. So we use pulse oximeter to try to help guide us. For the stronger type 2s, it's very helpful during illness to tell where things are at. But usually when someone's having difficulty breathing, you see them working harder to breathe, you see their nose flare, and you just see a lot more activity in their chest. For our kids with SMA type 1, they just will change color for you before you can tell. So we're using a lot of pulse oximetry to monitor and see where kids are at. If their stats are less than 95% while they're awake, it suggests that they may have some atelectasis, which just means collapse of the air cells. Or they may have mucus plugging, and they need to be coughed either way, so we do some airway expansion. And if it's less than 95 while asleep, they may not be taking big enough breaths, or they may have mucus plugging. So this is a question that's coming from the webcam that the pulmonologist has not suggested a cough assist machine for a type 2 patient. Is that okay for now? And that's a hard question. It depends. It depends on how strong the type 2 child is. For most, but I'll tell you, from my perspective, any child with type 2 probably should have a cough assist machine, because the problem is that when you need it now. Cough assist machines, you can't just call and get them that day for most DMEs. They don't stock them on their shelves because they're very expensive devices and they don't have a lot of need for them or a lot of call for them. So I recommend getting a cough assist machine to have available to you so that you can use it in an emergency situation and have it when the child develops a cold. Because they always get sick Friday night, about 8 o'clock. Okay. Am I wrong? And you cannot find a soul healthy. No. There's always a pulmonologist on call at the university. Okay? It's not always me, but there's somebody here. Okay, so let's talk briefly about secretion management. I struggle with secretion management a bit. There are medications we use to help drive secretions because the kids who don't swallow, and this is really an issue for the kids who don't swallow. So our kids with type 1, the weak with type 2, so lose their ability to swallow, they will tend to have a lot of oral secretions because they're just not swallowing them, and they have to go somewhere. So a lot of times they will drool out the mouth. So the things that I've used most commonly are glycopyrrolate or Robenol and scopolamine patch, which is the patch that just goes on the skin and you change it every 2 to 3 days. Nasal steroid sprays sometimes help, especially if the child has a lot of sinus issues, a lot of nasal drainage. Antihistamines may be helpful if there's an allergy history. I've done Botox with one person here with not totally satisfactory results, but it is an option. Some places are very skilled at it, where essentially they, you know Botox. And we like it here for the women, but you can use it on the nerves of the salivary glands, and it will paralyze those nerves so that they don't produce salivary glands. It requires injections every 3 months if it goes well, but it's one of those things that it's something to discuss with your doctor if there's a lot of problems with the other options. In surgical management, so a permanent option for dealing with a lot of secretions is surgery, where they actually take the glands out or they cut the ducts that drain into the mouth. Well, let's move on and talk about respiratory support options. So there's non-invasive ventilation, which includes BiPAP, or you can do by a ventilator, and invasive ventilation through a tracheostomy. And then let's also talk a little bit about palliative care. So non-invasive ventilation, our short-term goals are really to rest the muscles for breathing. So when we use BiPAP or a mechanical ventilator or whatever, what we find is that if we can rest the muscles during sleep at night, the kids seem to be stronger during the day. And that's most important for the type 1 kids and the weaker type 2 kids. And some, not necessarily weak type 2, also benefit from getting that respiratory muscle rest during sleep at night. Some of the kids gain weight better when we have them not work as much during sleep at night also. We're also trying to improve the exchange of oxygen. You breathe in oxygen, you blow up carbon dioxide. And we're trying to avoid intubation when the kids get sick. Because when they get sick, everything goes to hell in a handbasket in a very short period of time. Alex is going like this. So our long-term goals are to improve sleep. So kids with SMA are sweaty kids. They are. They're sweaty kids. You know, they sweat a lot and they're very warm. Sometimes using BiPAP improves that sweatiness during sleep. Also, the kids are up a lot. So is there anyone in this room who gets a full night's sleep every night? Wow, wow. Put your hands down. No, but my point is that most of these kids are up at night requiring to be turned because they're uncomfortable or they wake up. Something's waking them up. Sometimes we can also improve their quality of sleep by using BiPAP, even if they don't require it yet. And we think that it prolongs survival. So indications for non-invasive ventilation, which is what this category is called, or BiPAP, or mechanical ventilation, ventilation during sleep. And everyone agrees on this. Hypoventilation with oxygen saturations, or if you see the oxygen saturations are less than 90 on a sleep study and the carbon dioxide levels go up. They have obstructive apnea, where they block the airway during sleep at night. And also postoperative care is also an important time to use non-invasive ventilation. But specific to spinal muscular atrophy, I think all kids with SMA type 1 should be placed on BiPAPs early. Because I think it makes a huge difference, because when those kids get a cold, they're going to get into a lot of trouble, a lot of respiratory trouble. And if you have a BiPAP, they're getting used to it or they're used to it, you can bridge through the cold during that time. We'll talk more about that. So if their oxygen saturations are less than 94 while asleep, or their carbon dioxide levels are high, that's an indication also. In my experience, if a child with SMA during a cold needs to be intubated or needs to be on BiPAP, they should go home with the BiPAP. Because what's going to happen the next time they get sick, we're just going to play this scenario all over again. If they have chest wall collapse, I have a cool picture, or if they're not sleeping well. So this is a slide that was actually lent to me by Anita Simons. Dr. Simons in the UK. So the child at 6 months of age, you can see he sort of has this collapsed chest, and there's a sort of a cavity here. And then after a year, his chest just looks much better. He also has a little more weight on his bones, and this is also a little better. We've seen that, I've seen that in my practice, is that when we started BiPAP, we get nice chest wall growth, lung growth. And actually, we were playing with Jacob yesterday in clinic, and when we put him on BiPAP and measured his chest versus when it was off, he had a centimeter difference in his chest wall size. My challenge is finding the right mask, especially for the babies. I have so many more options when the kids get to be about 2-3 years of age, but for the infants, I'm limited. This is a small child nasal mask with comfort flap and headgear that I use most commonly. And then this is a SleepNet Mini-Me that I also use commonly in babies with SMA that I get started. And I keep looking for more devices. and sometimes your respiratory therapists come up with really great interfaces that I'm playing with. So, if you find something out there that works, please share. This is a nasal prawn system that will work for a little bit older child or a child who has a little bit larger nostrils. And this is a profile light nasal mask that works well, again, for older children. Canada and Europe, you can get a small child size, which is the smallest size. It's just not approved for use in the U.S. But some families have been able to get them from friends. This is a Fisher-Paykel FlexiFit. This is a nice mask for, again, a little bit older kid that's worked really well. That's a newer mask. So I keep my eyes and ears open. Every time I go to a national conference, I'm always bugging the manufacturers of these different nasal masks to see, okay, what do you have new for me this year? And they see me coming and they kind of cringe. But, it's very important. We have to have options because the issue is the skin breakdown. And if you can have a couple of masks, then you can rotate the mask and you can change the pressure points. So non-invasive ventilation devices, there's bilateral positive airway pressure, and the short term for that is BiPAP, or the abbreviation. But BiPAP's also a registered name. And there's also ventilators. I recommend, so I'm going to go through the settings. I recommend a spontaneous timed mode, which means that there's always a backup rate. The issue is that when our kids go to sleep, they may not take deep enough breaths to trigger the BiPAP to give them a breath. So I always provide a backup rate because then the machine will kick in and breathe for them, which is fine because, again, that gives them good respiratory muscle rest. Using BiPAP does not make a child more dependent on that device. It just helps rest them, and then they're stronger during the day. There's a lot of literature about this, there's a lot of adult literature on non-invasive ventilation in patients with muscle weakness, and this is what they're saying. So the device will synchronize with your child's efforts as long as they're taking big enough breaths. But when they go to sleep, sometimes they just relax so much that they don't take big enough breaths, and the machine can't trigger. But again, that's where the backup rate comes in. So there's a couple of major manufacturers. There's two that I work with. One is Respironics, and they have a BiPAP Synchrony, which has been discontinued. So if you have a BiPAP Synchrony, we need to talk about what the next devices that we're going to use. Because when that breaks, it's done, they're gone. The BiPAP AVAPS is what I'm generally using. It stands for Average Volume Assured Pressure Support. So for kids who are, what do you think about this? We figured this out yesterday, 55 pounds. I can actually set exactly how much air goes into the lungs. Otherwise, BiPAPs are generally based on delivering a set amount of air up to a pressure within the airways. So if your inspiratory pressure is set at 18, it blows air until it hits that pressure of 18 in the lungs, and then it stops. With this AVAPS device, for bigger kids, I can set a particular volume so that they always get the same amount of air every time. which is just more consistent ventilation. And I prefer that for the older kids because I think it's just more reliable. Because when you get a ton of secretions in your airways, you can hit the high pressure with a much lower volume. If that makes sense to people. Think about that. There's also BiPAP ST device. Some of my kids have done great with the BiPAP ST. I've had a couple kids not do well with the BiPAP ST. So that's a device where we just kind of have to trial and error. And then there's a new device that Respironics has put out called the Trilogy 100, which is a ventilator. It can serve as a ventilator. It can also serve as a BiPAP. And I'll get to the questions at the end. ResMed makes a VPAP device. There's a VPAP 3 ST and a VPAP ST, which is their newest one. So one advantage over this device is I can set the trigger and cycle sensitivity. One disadvantage is that the humidification doesn't seem to be as good. Both devices now, the Synchrony does not have humidification hooked up to it. The newer devices all have humidification on the front of the BiPAP, so they're all hooked together as one unit. So I generally use inspiratory pressures of 14 to 20, and expiratory pressures of 3 to 6. We want to keep that expiratory pressure low so that the kids can exhale against it. Remember, they're weak. And the higher you have that pressure, the harder it is to exhale against it. It's like sticking your head out of a car door and we're driving 55 miles an hour and trying to breathe when the pressure is really high. So we try to keep it 3 to 6. Tolerate up to 8 when the kids are really sick, but I wouldn't go much above. So when I set a respiratory rate, that backup respiratory rate, is I'm really setting it at a level that will match what the child's efforts are. So I make a determination based on age primarily. The babies with SMA type 1 breathe really fast. They will breathe 40 to 80 times a minute when they're breathing on their own. And when I put them on the BiPAP, the fastest I can have the BiPAP go is 30. But I can give bigger breaths with the BiPAP, so I don't need them to breathe as fast. And this is just something that I have figured out over time. Inspiratory time, that's just how long that inhale goes in over. So I can set that up anywhere up to 2 seconds. For babies, we set it really short, and for older kids, they like it longer. And there's something called a rise time. And rise time is just how long it takes to go from that exhale pressure to the inhale pressure. And it's usually milliseconds. So when it's set at like 1 on your BiPAP, that means it's 100 milliseconds. It's a very short period of time. But it makes a difference to some of the kids as to how that feels. So we just set that based on comfort. So there are a couple of home ventilators out there. LTV 950 is probably the most common ventilator we use for both non-invasive ventilation and invasive ventilation. There's other options. There's LP6 Plus, LP10, Newport, and then this new Trilogy 100 that's just been released in the last 6 months. And we use different modes of ventilation. I can ventilate by pressure, do a pressure setting, or I can ventilate using a volume setting on these ventilators. Disadvantages of doing mask ventilation, so mask over the nose. I generally use a mask over the nose. Sometimes we have to do mask over the nose and mouth if we just can't get a good seal, or there's just so much air leaking. But I can tell you that if the kids are constipated, they don't tolerate their BiPAP very well. So it's just really important to make sure that they keep stooling well. I've had kids come into the emergency room in respiratory distress with SMA because they were full of poop. So, having the bowels under good control and pooping every day is really important. Disadvantages, too, are the nasal bridge irritation, which we talked about a little bit. And one of the things that can happen if kids are wearing BiPAP for more than 12 to 14 hours a day is that they can get, I'd never heard it called this before, but at the FSMA meeting this year, someone called it BiPAP face, which just means that the top part of the nose up here, the nasal bridge, and the upper lip gets sort of pushed in. So it just looks like someone's been pushing in while the rest of the face is trying to glow. And that's one of the downsides of using BiPAP masks. So we try to get over to the nasal pillows or prongs just so we can get some of that pressure off the face because the kids are growing. So invasive ventilation is placing a tracheostomy, which is a tube that goes here essentially into the neck and into the trachea. It's not an acute intervention. We don't do tracheostomies emergently in this population because usually we can get people intubated. Trachs are done emergently when you cannot get an airway any other way. But generally in the SMA population, the kids are intubated because of our illness or difficulty breathing. We don't do trachs right away. We talk about trachs. And it may be needed, though, if a child's not able to tolerate non-invasive ventilation. Some kids out there just do not do well with a non-invasive BiPAP. If they're having frequent or difficult to manage death spells or crashes, where they turn blue suddenly and you're just like begging them all the time and doing coughs with them all the time. Or if they're needing nose mask ventilation for 24 hours per day when they're healthy and they're just not very stable. It's a choice to do tracheostomy, I think, in our population, especially kids with type 1. In my opinion, it's not indicated in kids with type 2. We can manage them non-invasively without needing to do tracheostomy. But that's based on a ton of experience here that you all have allowed me to have. So palliative care, people always sort of get a negative connotation when we talk about palliative care, but I'm actually very impressed with what palliative care really means. It really means whole family or whole person care. It's where you look at the big picture. I mean, I'm a pulmonologist, so I'm looking at the breathing component of your child's care, but I may not pay attention to how that impacts the entire family, like the siblings. And our palliative care docs are very good at sort of figuring that all out, and they also look at pain management if there's a lot of pain issues. Our goals when we talk about palliative care are to prevent PICU stays and trach if we can, provide symptom relief, we talked about briefly, and also support. And non-invasive ventilation can also be used for palliative care. Palliative care does not mean you stop at everything. It's a process. Okay. So we're going to change gears and talk about acute management when the kids are sick. So we sort of laid the groundwork for everything else. So, you know, the biggest enemy for your kids are colds, viral respiratory infections. When your kids get a cold, and actually this is true for everybody gets weaker during a cold. And your kids who have muscle weakness already get even weaker when they get sick. And they have a lot more airway secretions. I mean, the nose runs, the lungs make a ton of secretions, and you have to get them out of the lungs. And the answer is not supplemental oxygen by itself. So what that means is that if your child's having difficulty breathing and their oxygen saturations are low, you don't throw on oxygen and walk away. You're doing all the other stuff that we've talked about. You're doing cough assist, you're doing airway clearance with chest PT or vest or whatever is working, trying to get those secretions out. It's not that we never use oxygen, we just don't use it as the only thing. So we talk about acute care when the kids get sick. We're trying to keep the oxygen saturations normal, trying to reduce the lung collapse, get those secretions moved out, and we're trying to limit the need for intubation. So what we do, or what we actually recommend you do at home when the kids get sick, is some form of secretion mobilization, SPT, VAS, IPD, electric percussor for 15 minutes, cough assist, 4 sets of 5 breaths, followed by suctioning, and then drainage for 15 to 30 minutes, and then cough again, more suctioning. And again, this is done every 4 hours, trying to stay ahead of those secretions, and you cough as often as you need to in between. We're using oximeter. If the saturations are dropping, you usually cough. And we prefer cough techniques, having the kids cough rather than just suctioning. But when you cough them, oftentimes you have to suction if they're not able to swallow on their own. So we also use BiPAP. The purpose, again, of BiPAP is to decrease the respiratory muscle work. I don't use CPAP in patients with spinal muscular atrophy or anyone with neuromuscular weakness for that matter. It doesn't provide enough rest or support. So CPAP is not indicated, it's BiPAP. We're trying to improve the oxygenation, we talked about that, and again, may decrease the need for intubation. Okay. And the kids may need to be on BiPAP day and night, except for when they come off for airway clearance and coughing. And my cutoff is that if you can't keep the oxygen saturations greater than 90% at home, they probably should be in the hospital, because I've got shifts of people who work to do this. You know, my respiratory therapists change shift every 8 to 12 hours, and there's several of them. There's just 1, 2, maybe 3 of you if you have a nurse in the home, trying to do these treatments really frequently. When they come into the hospital, if they have atelectasis, pneumonia, need oxygen, we're doing that airway clearance protocol every 2 hours. And the treatment probably takes about 40 minutes to do from start to finish. So, it's an hour of a treatment, hour taking a rest, trying to stay ahead of those secretions. We use oxygen therapy if we've got all the other things in place. Sometimes we need to intubate because we're so far behind the 8 ball and we just can't keep up with the secretions and the child is so exhausted. So then we intubate. We do the airway clearance treatments very aggressively, and then we work to get them extubated. And again, trach is not an acute intervention. When our kids are sick, it's also really important that they stay hydrated, because if they get dehydrated at all, the secretions in their lungs, all the secretions they're making, turn into concrete. And then we're trying to get those out. So we're trying to loosen those up as well as maintain oxygen saturation. So if they're having difficulty tolerating their feedings, because for many of the kids, and I don't have a good explanation for this, but many of the kids, their stomachs just stop working. And that's fairly common. I call it gastroparesis or paralyzed stomach. Some kids don't have that much of a problem, but many kids do. So if your kid's not tolerating any fluids, they also need to be in the hospital to get IV. Usually it's during illness. What have you seen, Abe? Usually it occurs most frequently during illness. That they just, they're filling up with secretions, have a really bad cold, and you cannot get the feeding in. The food just doesn't move. And Pedialyte sometimes doesn't move. And if that's happening, they need to be in a hospital. We have to do IV fluids because we have to keep the kids hydrated. And the other thing is that they need to have a nutrition source. The kids the weakest kids, the type 1s, should not go longer than 4 to 6 hours without some sort of sugar source or source of nutrition. They need the sugar, otherwise they will develop ketosis. The body they don't have enough glucose stored that they will start breaking down fat and protein and other things. And that will lead to something called ketosis. So they have high ketones in their blood and their urine, dehydrated. And that can cause other problems. So it's just important that they stay hydrated, that they have a good nutrition source. And if they're not tolerating feedings, we're using the IV nutrition, or TPN, some places called TNA. We also aggressively use antibiotics, and that's actually part of the standard of care document. Yes?
Is there another indication when that trigger is?
No, that's the most common one. I thought you had an oximeter. No? We can talk afterwards and take care of that.
Do you have one for all your...
Pretty much, maybe not, but I don't know. What were you going to say?
We have a manual.
Yeah. So for the most part, I provide pulse oximeters or order pulse oximeters for kids with SMA. But I think, but some of I'll tell you the reason why Jonathan probably doesn't have one is because he was so healthy for so long. He didn't actually need BiPAP until, So we probably just didn't do all that with him. But yes, we can get you a pulse oximeter. Okay, well, is there another question? Okay. Yeah. Right. So just for the webcam people who cannot hear a word you said, is that the question was, or actually it was a statement. There really wasn't a question there, but the statement was finding the right antibiotic. That what they do, and their child has SMA type 1, is they will, you have swabs at home, they will swab the back of the throat to find out what the bacteria is, that may be contributing to the illness so that they can direct therapy, antibiotic therapy, more specific to what bacteria you find. For kids with SMA type 1 who don't swallow, they often develop Pseudomonas as the bacteria when they get a viral illness. So we frequently find... Go ahead. Why do you let him talk? And that's what we do, is actually okay. So yeah, the preferred method is to suction secretions from the back of the throat. Do airway clearance, cough them, and then suction those secretions and send them for culture. And it'll take a couple of days to get it back, but then you can direct antibiotic therapy more specifically to what's going on. Okay, yes? Yes. So sometimes there's different, usually we prescribe one antibiotic right away, do the culture, the sputum culture, and then see what grows, and we may need to alter therapy, depending on what we find.
Is it important?
That's preferred. It's preferred to do that. Now, we don't always. It just depends. Like if they come in the hospital, we're getting sputum cultures, just because they failed outpatient therapy. Okay. So there's a lot of controversy about nebulized medications. We'll just say it like that. I tend not to use nebulized medications on a day-to-day basis. And when kids come in the hospital, I think it's a mechanical problem. To me, the issue is that they can't get the secretions out of their lungs. So we're working very aggressively with the chest PT and coughing to try to move secretions. Sometimes we do use these medications, but that's usually not our usual. Usually it's when we get into a corner and we're not making progress that we'll start. My recommendation is that I think on a day-to-day basis, unless a child has asthma or has shown that they have need something else. Like some of the kids have had a lot of pneumonias or a lot of respiratory illnesses. Those kids may need to be on inhaled steroids all the time, just to keep that inflammation under control. That makes perfect sense to me. I mean, it's sort of like these other things have happened, and so we need to be on inhaled steroids. So it's a trial and error basis is the bottom line. I don't have a specific recommendation across the board that every child with SMA should have something or other nebulized. Okay, so when we have our kids intubated, we have criteria to get them extubated, and we work very hard to get them here. So no fever, not needing oxygen, chest X-ray looks great. They're off most respiratory depressants, meaning the sedation medications, and we're not suctioning them for secretions very often. And then I work with our ICU to not stress the kids, not poop them out before we extubate them, but to really try to get them from being intubated to their BiPAP. The thing to know, though, is that after we've extubated kids, the first 24 hours after extubation, they have a ton of secretions, so we have to do airway clearance very frequently. So these are recommendations for in-home equipment for type 1s, and it varies, less equipment for type 2s, and less for type 3s. So this is like, if you had a type 1 and everything, this is the everything list. The type 2s don't need all of this. Type 3s don't need, might need a cough machine. Most type 2s don't need an ambu bed. And most don't need supplemental oxygen. And I apologize, I should have made a list type 1, type 2, type 3, and I didn't think about it until I got to this slide and went, oh. I do recommend routine immunizations now. It's a big deal. Everyone should get their flu vaccine as soon as they can get it. We're going to have our vaccine sometime in the next week or two. Flu vaccine. H1N1 vaccine is still in development. It's in clinical trials. They're testing it right now. They hope to have it available for us in October. And if things go really well, next month. They're anticipating 2 shots, 2 injections for the H1N1. So we're looking at probably 3 injections for influenza or this fall. So please get your vaccines. RSV prophylaxis, the guidelines have changed, but the thing to know about the Synagis is that Synagis has never been approved for kids with neuromuscular weakness or SMA who were born at term. The guidelines about that have not changed. What happens is that I, as a provider, write to your insurance company begging them to pay for Synagis injections because the consequences of your child getting RSV under the age of 2 is severe, life-threatening, very costly. So it's requesting a prior authorization for that. So right now, Synagis has never been approved for SMA babies born at term. New recommendations that have just come out this year have not changed. And we just beg and grovel for it. The thing about RSV and Synagis is that Synagis isn't a perfect drug. The only proven ways to avoid RSV, and RSV, for those of you who don't know, respiratory syncytial virus, it's a nasty virus for kids under the age of 3. It can be, where they have a lot more coughing, wheezing, difficulty breathing. The things that are proven are avoiding people who are sick, good hand washing, and the hand sanitizer. Those are the 2 things that work. And then we like to also try to get Synagis, but I don't know how it's going to go this year.
Dr. Schroth?
Yes.
Any special vaccine for our kids? I know there's been things talked about as far as, getting together. Is there that we should be watching for bad reactions? Based off what you know.
So what I know is that you cannot get the flu vaccines together. The regular influenza and the H1N1 will be separate. We don't know what the reactions to the H1N1 vaccine will be yet. We just don't have enough information. They're still developing it. They're still testing it. Nations that are coming. So the question was regarding influenza vaccine this season. Will we be able to get them? What are the recommendations? What will be possible side effects of the vaccine at this point of H1N1? And can you get H1N1 together with the influenza vaccine? And no, you cannot get them together. And we don't know all the side effects for the H1N1 yet because we just don't have that information. Okay. Do you know who's going to come to your house if you call 911? Yes? If you do not know who's going to come to your house when you call 911, find out. Emergency medical services are quite variable from community to community. We've learned this the hard way across the country with SMA. Your EMS people have never seen another child with SMA, chances are. So invite them over to your house, take your child over to meet them, whatever it takes, but have them know who your child is before you call them in an emergency or crisis situation. One of the things to negotiate or to know is that some of the EMS ambulances will not take your equipment because they can't power it, and they don't know your BiPAP. So if you get to know them or have them get to know your child before your child is acutely ill, you have a better chance of them being able to work with them and just negotiate in advance, will they take your equipment or not? What can they provide to your child? And they need to know what your child needs. So when you get home, early next week, even this weekend, I don't know how they all work, but get to know who comes when you call 911. And the other thing is keep yourself CPR certified. The type 1s and type 2s keep you on your toes. Okay. This is the International Registry if you're interested in research. It's the Indiana University Registry. Okay. So, anyway, so this is just my conclusion. Chronic respiratory management includes methods for airway clearance, non-invasive ventilation. Routine immunizations are very important. Discussion about care should occur early, and having your care provider team put together is so helpful. We have a neuromuscular clinic that we do that includes myself, rehab, in orthopedics, and then we have dietary, PT, OT. It's wonderful. We're having PT, OT, and nutrition talk with you today. So acute illness, they need more airway clearance, more secretion management. They need to be on support 24/7. Need nutrition, hydration management, and we have a low threshold for antibiotics. So I'm going to read some of the questions that have come. Okay, what do you think about albuterol treatments with the nebulizer? I think I addressed that, is that it depends. If the child has a history of asthma or is shown to benefit from it, I would do it. If your child has never had asthma and the doctor's just prescribing albuterol and it's unclear why, I wouldn't do it. I think it just keeps you more busy. And you guys are so busy as it is. Isn't it beneficial to type 2s without aspiration issues to expand the intercostal so they don't get contractures? Yes. Yes, so type 2 kids with SMA type 2 who are not on BiPAP do benefit from using either cough assist machine on the inhale mode only or using a bag mask to help expand their chest wall. So yes, I agree with doing that. Because it's important to keep the intercostal muscles and that chest wall stretched. Because the intercostal muscles do not work well in type 1 and type 2. Oh, at what age do kids require a sleep study? And there's not a set age for kids requiring a sleep study. I do not have a pediatric sleep lab, so I'm at a bit of a disadvantage regarding sleep. I don't do sleep studies on my type 1s for the most part because I don't get the information I think is most useful. Which to me, their heart rate, I'm always amazed at how much their heart rate tells me the story. If their heart rates are high, usually their heart rates jump up before they're really sick. Like that's the warning. Their heart rate will jump 20 points compared to their usual. And I don't get that information back from the sleep lab about heart rate. What is their heart rate doing when they're BiPAP? So things that I think of, so what makes me want to do a sleep study on someone is usually a child with type 2 who I'm just not sure, do they need a BiPAP or not? Their chest wall looks okay, but maybe they're having some sleeping difficulty, they're waking up frequently at night. Then I will do a study. So it's really dependent on symptoms, how well they're sleeping at night, as to when I would do it. At type 3s, I've done, so one of the issues with type 3s is that sometimes they gain a lot of weight. And if you gain a lot of weight, it's so much harder to move. So, there's a balance there between being too thin, too heavy, and that nutrition will address that more. But on my heavier kids, I will do sleep studies sooner because I worry about obstructive sleep apnea. Okay, so that's the questions from the webcam. Are there other questions you guys have? Yeah.
Do you have an opinion on using the?
If that works well, I would use it. It's an option. For the type 1s, they generally there's differences between type 1 and type 2 and how they tolerate BiPAP. Type 1s, you put them on a BiPAP, they don't, at first they don't like it, but then they pass out every time you put them on it. They just get to that point where you put them on and they pass out. For type 2s that are a little bit stronger, they will require a longer period of time to adjust. They may need the ramp. And what ramp means is that you start at the low pressure, that exhale pressure, and you gradually work up the inhale pressure with the exhale pressure. I would do whatever works. I'm very flexible in that way.
Okay.
So if that works well.
Okay.
Oh,
Thank you.
I'm sorry. So the question was, in using a BiPAP, did I have an opinion about using the ramp feature? And I think for many type 1s, they don't need the ramp feature. For some of the type 2s, as they're acclimating to the BiPAP, they need the ramp feature. And for some other kids, they just like it because you go from, as I said, it just gradually works up that inhale pressure. So the question was, what and how much drugs do you use for intubation to manage the patient while intubated, then extubate? I'm not exactly sure what you mean. We use medications when we intubate so that it's not a miserable experience, because it's actually a miserable experience if you're awake and being intubated. And I have an ICU team, and I trust my ICU team to do the right thing to provide those medications because I'm not an intensivist, I'm a pulmonologist. And then while they're intubated, many kids are very anxious while they're intubated because it's a weird thing to have a tube in your mouth and you want to talk, because all of our kids want to talk. And if you take away their ability to talk, they are so upset with us. So we will use medications mostly to help keep them comfortable, and then depending on how long they're intubated, we'll back up on these medications as they tolerate. So this question is, do I believe in prophylactic antibiotics during cold months? I've not used prophylactic antibiotics through an entire winter with someone. I tend to just use antibiotics when the child starts to get sick. So it's not whether I believe or not. Some of it just depends on how often. If the children are on a child is on antibiotics a lot, I might consider using prophylactic antibiotics for a significant period of time. So I'm not opposed to it. It's not right or wrong. We don't have enough evidence to say what the right thing to do is. Other questions?
really don't want to go there.
So the question was, I made a recommendation about getting to know the emergency medical services, but what about the emergency room? Should the families also be getting to know who's at the emergency room? And the answer is yes. I mean, you're right, Peggy. That would be great for everyone to get to know the emergency room people. I just don't know how to do that yet. I mean, that's sort of like the next major issue I see that we have to tackle within SMA care is emergency medical services, emergency room care, and how to bridge some of the gaps that are there. So I know if someone, I don't know, if someone showed up in our emergency room here at UW and said, hi, we're not sick, we just want to meet you, and we want to see what you have to offer. I'm not sure what would happen. I would hope so. I just don't know, and I'm just thinking out loud as we're talking. I think you're right, probably the nurse manager, because every emergency room has a nurse manager. Someone is managing that unit from the nursing perspective, as well as a medical director. So calling and, that's a great idea. Wonderful. Get to know who these people are. Because for a lot of the kids, what is happening in the emergency room is that you're going there, you're getting what we call triaged, stabilized, and then you're being transported somewhere else where they can actually make optimally. Sorry, I know.
Always change the doctors and the doctor, so that's the only thing you fall into.
So I'm just going to repeat it. So what one family does is they have all of their information on a memory stick or memory stick.
From what you do.
That includes medical history, recommendations from me, that the respiratory care protocol, what the diet is, and then diet during illness, and all that is on a memory stick that they give to the emergency room staff when they get there. And then they also get the child's website, which also has a tremendous amount of information about her. So for newly diagnosed patients, newly diagnosed type 1s, when do I recommend the pulse oximeter? And I actually ordered for them as soon as they see me. But I'll tell you what the limitation is. The limitation is teaching families how to use it. Remember when you first got a pulse oximeter, how bizarre that sort of was? And what do you do with that information? I mean, we try to teach you, but part of it is a learning process. There's a learning curve with all the equipment we give you. I sometimes try to stand on the other side when I'm talking to families that are newly diagnosed, trying to figure out how overwhelming all of this information I'm delivering to you is. And I keep trying to figure out what can I tell you, what should I wait to tell you, should I just lay it all out, realizing that you're only going to get 10% of what I tell you. And then we just do it again next time. I don't know. We can chat later. Thank you all for your attention.